Thank you. Sorry I'm peeling in and might peel out again. I apologize for that, but busy summers I'm sure you've all had. So I'm really happy to be here today, and I know we have a broad background of expertise here. I am a lipidologist. Dr. Lieberman and I have actually crossed paths at the NLA before, and my practice is a little bit more narrow than his. He's doing preventive cardiology as a whole. Our practice and what I've been doing for many years since 2006 has been exclusively lipids, so we're kind of the place that people think of when their cholesterol is abnormal. And oftentimes what we see in our clinic is people who can't get to goal, and 95 to 99% of people, depending on the time of year, are referred from their other providers. So they wouldn't necessarily know they need a lipidologist unless their provider says, I can't get this managed, you need to go see them. And so that's what I've done for many years, and I used to work in a healthcare system, and I broke loose in 2012 and started my own practice. And just to give you a little background about how this all crosses into meeting Alex and getting into the wellness realm is I was approached by a mom at elementary school who was a broker. She was a risk advisor, and she said, I feel like what you do could help companies too. And I was like, did that, don't like it. Worked on some programming with a company in Ock Health when I worked in a healthcare system, and it was all fluff and no thank you. And she said, it's changing. I think you'd like it. I think you want to come and talk to my client. And so we started working on a pilot program with a company, and really found it to be a great fit, and did find that now companies are realizing the costs of healthcare, and they're trying to help their employees be healthy. And one of the big eye-openers was I have to fight within the healthcare system when I see a patient in clinic to get a dietitian paid for. In general, you can't get a dietitian paid for to see your patient unless they already have renal disease that's significant or diabetes. You can't get them to see them for the prevention end of things, and that's very frustrating. And when I go and talk to a CFO of a company and I say, you know, it would be great if your employees could talk to a dietitian, prevent, they're like, yep, that makes sense, let's go, you know. So it's been a really fun conversation to work with companies. We work with kind of a select group of companies who really want kind of chronic disease management and high-risk people, but that's kind of our other division where a lot of our staff works. So that's where I'm at, in some of what keeps me busy is working in some corporate wellness, and then also in a lipids clinic in a traditional medical practice. Said, talk about what you feel like. So here it is. I decided to kind of go national and talk to you a little bit, and I hope that this isn't a downer talk. I hope that this is a very positive of like why you're here today and why we need to talk about the prevention end and lifestyle and how important it is. But I think that we have to really talk about where we're at, and that there's some problems, and that will give us a little bit of intensity to what we're doing and to get things moving, because we're not doing so well. So an initiative that I'm working on in the foundation of the NLA nationally, and working with a really cool organization called the National Medical Association, which is the largest group of Black physicians in the country, is we're working on this initiative called Take Heart to Health, or Take Health to Heart. And what it is trying to get to some of the root causes of why we're failing in cardiovascular disease, and really try to make a national impact. And so it's kind of exciting, but the statistics that get us going on this are kind of bleak. So I want to talk a little bit about that now. All right, so that's me. And so our goal is to try to drive some public policy change nationally, and to try to make a difference and really change ultimately the trajectory of cardiovascular disease, because it really is a national crisis and it isn't talked about enough, we feel. So since I know a lot of you aren't clinicians, this might be kind of basic for some of you, but what is cardiovascular disease? Because it's kind of a wastebasket term sometimes that people use, but it's basically a spectrum of diseases involving heart and blood vessels, and it is the leading cause of death in the US. And some people don't realize that, some people very much realize that. But atherosclerotic disease, the buildup in arteries, is the most common form of that. And there's some key risk factors that lead to that. And Dr. Lieberman is an expert in this and deals with this every day. And there have been over 22 million Americans who have been diagnosed with this disease, but sadly we have many more that have no idea they have it until maybe their fatal event or maybe that life-changing event. And it gives us a huge cost in American society. It is the #1 cause of death, not just among old people. A lot of people think it's amongst old people and they think it's amongst old men. And it's very much not so. It is also a leading cause of premature death in young people. And it is 12% of total US health expenditures. So it is an extremely costly disease. We lost progress in COVID because people didn't go in for prevention. They didn't go in and get diagnosed. They didn't go in and take care of themselves because they were too worried about holding up in their house and not getting some other disease. And so we lost significant time. And at first, when these statistics started to come out, we thought that it was because of COVID, but it's not. And that is what is most troubling, is that COVID is part of this uptick. But for years, we made progress and more progress on cardiovascular disease prevention and treatment, and we really were making progress on stopping deaths. And now we're starting to see an upward climb, and that is really unacceptable, right? We're spending that much money on healthcare, and people are dying more than ever. Like, not okay. So what is happening, and where is this going? Well, we're doing a really great job with some populations of giving them this cutting-edge care, but we have some really key populations that are getting left behind. And those populations are growing, and that is very troublesome. And there are some pretty basic ways that we can address that, looking at this and talking about it. So one of the groups that we're missing is women. There's a few of us in the audience today, right? We're doing a terrible job with women and cardiovascular disease and identifying it and treating it. A really hot topic is rural America. Rural America is not getting the screening and prevention and services that larger cities and more up-and-coming communities are getting, and they're getting left behind. And we're seeing mortality rise in rural America from treatable diseases. Ethnic and racial minorities, we know and we see a lot of these statistics, but it just keeps coming in our face, and we aren't making enough of a dent with it, and thus our partnership with the National Medical Association. Black Americans are more likely to die from cardiovascular disease, they're more likely to be undertreated, they're more likely to be unidentified entirely. So there are a lot of barriers that cause this, and a lot of reasons why we're not seeing an uptick in prevention. There are clinical barriers. Tim talked a little bit today about, the providers complain that they don't have enough time in clinic, they don't have the resources. There are social and economical barriers. We talk about social determinants of health, absolutely. There are, the cost of healthcare is so high now. People with high deductibles then opt to not get prevention, not go in, because they think that's going to lead to more costs they can't afford. There are insurance barriers where we can't get things approved that we know work, despite the medical necessity of it. And there are health system barriers. And so we're trying to work on some of those big things along the way. So 50.4% of the US population is women by census data right now. And it's really unfortunate that 60 million women are living with some form of heart disease, but many of them don't realize they have it. And that it is actually the leading cause of death in women in the US. But people think about breast cancer first, oftentimes. They don't think about cardiovascular disease. They don't think about women dying of heart attacks and strokes. And it happens way too often where I have a patient that goes to the emergency room and gets sent home without an adequate cardiology workup, without a stress test, because even providers have this bias that they don't think women get heart disease. And part of where that comes from, which is so frustrating, is that, has anyone ever heard of, I'll be very impressed if you have, the NIH Revitalization Act of 1993? Anybody heard of that? It's a really big deal for women. That was when they had to pass a law in Congress that women had to be included in trials, clinical trials. Until then, most trials largely included men. So when they say, oh, women don't seem to get heart disease, they didn't ask us, they didn't study us, they didn't look at us. And so a lot of the primary prevention and what works in lifestyle and early treatment, we weren't included in those studies, and it was assumed we had the same disease as men. And so then this bias over the years has happened where they assume we don't get disease. They assume, well, that's an atypical symptom. Turns out women have different symptoms than men. So if they're not atypical, they're female symptoms of heart disease. And that if we don't match what a provider thinks is heart disease symptoms, we don't get screened, we don't get treated at all. And so we're seeing this inherent bias in healthcare that then leads women to be undertreated. We have statistics that women who get put on therapies at all are left at suboptimal treatments. They are not gotten to goal like we are for men. Women are not screened as young. It's kind of like, oh, you're in childbearing ages, so we'll just wait until after all that's over. So we don't get treated until menopause, and then our risks start to go up significantly. And so many of the things that could really change our trajectory towards heart disease when we're younger are never given to us, and so we have to fix that. And so when we think about how we're going to actually fix this and who we're going to target these therapies and lifestyle towards, we have to think about half of the population, and we have to do better, because this is starting to wreck those numbers. So nearly half of women don't know that cardiovascular disease is actually the #1 killer for women, and their answer usually is they think it's breast cancer. It's a really important one, but we do, I think, a better job of screening for that and raising awareness compared to heart disease. There are some risk factors that men don't have that women have. Some of the treatments, if someone did have breast cancer, some of the treatments predispose us to future heart disease. Some of the autoimmune disorders are much more common in women than men. And so there are certain things that set us up for more disease from a young age, and we're starting to see that kind of ripple as we see more and more autoimmune disease. As I mentioned, we're underrepresented in clinical trials, so there's this perception that these things aren't as important because we don't have the data. So how are we doing in Wisconsin? The government has done really nicely over the years to set up this plan for the goals long term for how we're going to keep people healthy and what our targets are. And in the Healthy People 2030, we like to compare, like, where are we to that goal? And there's, unfortunately, we're still above the rate where we're going to be able to meet that healthy people target of per 100,000 down to 71 people having cardiovascular deaths compared to 88 we're at right now. So we've got a ways to go, but we've got a few years to work on this. In addition, stroke, we're a little bit above where we want to be, but we can, I think, pull that down. This is kind of interesting data, and the purple is where we're worse than the national value. Pink is the national value, and then the light peach is the better than national value. And so we're doing okay, but when you look at the numbers, like, barely, right? So when we look at the prevalence of ASCVD, we're 7.6% in Wisconsin and 8% in the US as a whole. So we're kind of right on average. When we look at the death rate, we're right there, just barely below the average. And heart attacks, we're just barely below the average. Stroke, we're just barely above it. So we're kind of at the average, but the average for the US isn't very good. So we want to improve that. When we talk about costs, this is an estimated cost of cardiovascular disease for Wisconsin, and we're talking about $1.98 billion a year. It's a pretty staggering amount of money that's spent on cardiovascular disease. And so if people maybe don't care about the individual getting the disease, but they care about the money, this is one that money talks, and we have a lot of money that we need to be spending on prevention, not treatment of these. So health risk factors, where are we? Again, if you look at the purple, those are ones that are worse than national average, and the peach is where we're doing a bit better. And so we're doing okay with smoking, we're doing okay with physical activity, we're doing okay in some of the kind of chronic conditions. Insurance coverage, we're doing okay. Cholesterol screening, we're just a little bit below on blood pressure. But one that we are really not okay on is I don't think this will shock anyone, binge drinking, so alcohol use. And I always say that I did part of my training in Kentucky, and when I moved to Kentucky, I grew up in Wisconsin, and when I moved to Kentucky, I was like, holy smokes, they smoke a lot here in Kentucky. Like, wow, they have a tobacco problem. And then I moved back to Wisconsin, I was like, oh my gosh, we drink a lot here. Like, I hadn't ever lived anywhere else to realize, and that's where most of our family members and patients are at, is that they don't know that that's not normal and that we are a binge drinking culture in Wisconsin. And it really does take a toll on our health. And it is a cardiovascular risk factor. We're seeing a lot of chronic liver disease, and we're just really seeing an impact on that. And sometimes I'll work with companies, and one of the first things that we'll talk about is, maybe your employee celebrations can't be at a bar. Maybe they can't be, we've got to, when we're trying to get that culture of wellness, we have to talk about moving the expectation towards healthy on all ends of things. And I know that it's a culturally popular activity in Wisconsin, but maybe we have to change that understanding a little bit and really make a difference. So, on nationally is trying to improve access to care for those that are getting left behind, addressing some of the socioeconomic barriers, and improving that quality of care through some updated measures. And this is just an example, and I don't want to get too far into it today because I do want to talk a little bit about lifestyle and the benefits. But one of the systemic problems, and Tim alluded to this a little bit, is when you only have so much time with your healthcare provider in a clinic, and they have to go by certain rules that they have to abide by, some of those are quality measures. And quality measures are the boxes they have to check in the electronic health record of the things they talked about with you that have been deemed beneficial. And so those quality measures move to the top of the list of the things that time is spent on in that office visit. And they're often judged by that and their performance. Sometimes their pay is connected to that. And for example, for cholesterol, we have a very flawed quality measure right now. There was a guideline written a few years ago that was widely misinterpreted in 2013 about using high-dose statins in people, and the quality measures of measuring cholesterol and getting to goals and including lifestyle got thrown out, and it was basically, is this patient on a statin? And that quality measure, those are very hard to change, and it really takes something that's a huge ripple before those change again. And that quality measure needs to change, because then that's what happens is people are on, they find out they have high cholesterol, they're not given any information about their prediabetes or how to change their lifestyle or how to do some of this through non-pharmaceutical measures, and then the box is checked of, I got them on a statin, and they move on with their day. Now, for someone who's really high risk, we use statins all day long in clinic. They're not a bad thing, they're a very good thing, but not instead of lifestyle. If you need them with lifestyle, if lifestyle would succeed first and you're not very high risk, then those shouldn't be the goal at the end of the day. So we're working nationally to try and help people at the healthcare system level, and more importantly at the legislative level and at the government level, to understand how influential these quality measures are and get them changed back to, is their cholesterol ideal and can we get it down? And even when people get on a statin, they're not treated to optimal goals. So we're really having a lot of barriers that are self-inflicted that we need to work on. Never screened, as I mentioned, and so they don't have access to primary care that is well-versed in understanding that women have risk factors and that some of these risk factors aren't as obvious as men, and they maybe can't afford to get in for health care. They don't understand that a lot of preventive care is free, or they don't have coverage, then it really isn't free as far as prevention. One of the programs that we're promoting is the CDC's Wise Women program that pushes for screening of women in that middle-age category who are low income or uninsured or underinsured, that they can get in and get screenings at no cost, because you can't make changes if you don't know what you need to change. If you don't know what numbers are abnormal, you can't even get started on changes. So we have to get those numbers first. In our program with our corporate wellness, we do some consulting. Like I said, sometimes I'll come in and I'll just talk with companies about, their wellness culture and what can be done and where they want to go with things. We do have a select group where we have wellness coordinators on site. We do some health coaching. We do some programming that's kind of like little isolated packages or integrated. And we do have some chronic disease support and care navigation, and we have nurses and a pharmacist and a dietitian on our team that work collaboratively, and we're very much like Astia and some of the other programs you're hearing today about team-based care and working with that. And that's been a real pleasure for me over the last few years to work on that. It's really fun because I'm seeing the healthcare systems have a lot of fragmentation. And I know it depends on where you live, what you're seeing, but I always say I grew up, anybody been to Viroqua, Wisconsin? Anybody been there? A couple people. So I grew up in a small town, Viroqua, Wisconsin, and Dr. Starr was our family doctor, and Barb was the nurse. And I say over and over nowadays, like, if we had Dr. Starr and Barb, this problem wouldn't exist. Like, we've taken away that core clinic of people, that home where you go in and people know you and they knew your parents and they knew your brother and sister and they take care of you and they get you in really fast. And I did a rotation in med school in my hometown, and the country doc that I followed, if there was a little lady that had a hard time getting out, he'd walk down to her house at lunch and go see her. And he would go home for lunch, and his wife would have a list of all the people that called that morning. This is before HIPAA. So that called and were like, I just have one question for the doctor. And then he'd call them all back during lunch, and it would be like a 30-second conversation because he knew them. They knew that they just had a quick question and things, and that care has gone away. And so we need to kind of get back to that. And what I've enjoyed is working with companies and if self-funded and direct primary care is you can start to get some of those models back of people going in, having a place that people know them, it's close to their employers, they get access to wellness and lifestyle prevention and things. And I think that that's really what's needed is that medical home and that primary care. If you have a really great primary care provider, you often will get your screenings, you will get your advice, they will get you to who you need to be because they care about you and you care about them. And so I think there's a lot that can be done. We're trying to raise awareness, we're trying to get those boxes checked of what needs to be done in the healthcare systems, but also really supporting what's happening in the direct primary care and in the direct service categories to really see that impact of change. And so that we can make a lot of difference. I know that Alex talked this morning about diabetes prevention and the importance of that. There's so many things we do in clinic that are all about just a little bit of weight loss, just a little bit of change can make such a dramatic difference. And so getting those tools and that help for people is so essential. Our dietitian is available to anyone who sees me because it's so crucial. And sometimes the small bits of advice that they need and the small amount of time that she spends makes all the difference in the world. And she will counsel on fitness and exercise too. And we see just such wonderful changes with that. So years ago when I was practicing, I worked in a cardiology clinic when I was in the healthcare system, and we actually had cutoffs that above 300 they'd get a stress test, all that. I'm seeing that change. So I am not seeing, at least in the Fox Valley and kind of my national colleagues, I know that there's any level that triggers some kind of procedure anymore. In fact, I almost get uncomfortable sometimes because people could have a calcium score of 1100 and my cardiology colleagues wouldn't necessarily do any increased testing if they're not symptomatic and they're very active. And I'm like, that's really high. But I understand that, and I understand that data. So I'm not seeing it as much as I used to, but there was a time. But it does give us pause when that's there because it kind of helps us say, okay, there's disease here. It doesn't mean that there's a significant blockage, but there's disease. And so on the prevention end, it really moves up the aggressiveness of what we're setting as goals.
I don't think that there's a more important test that you could recommend to a patient in this country than a calcium score. The problem is that you're including the text for the behavior of the doctors who are doing something with that test. The test is amazing. The test can save lives. The test has been proven to increase preventive treatments, right? So there's been studies that have looked at calcium scores. When you tell the patient their score, at the end of 1 year and 5 years, the patient's more likely to be on a statin, more likely to be on aspirin, more likely to be exercising, more likely to be eating healthy, which is what all that we're talking about, just from the result of this one test. Yeah. The problem is that we work and live with a healthcare system that rewards interventions and procedures and not what we're talking about, which is time spent with patient, not with counseling, not with any of these things, right? So if you take this test and put it in the hands of bad actors, you're going to get they're going to just see the cash register, cha-ching, cha-ching. They're going to see, oh, this person has heart disease. That's a license to put in, to get 16 or 25 RVUs, and I get paid $100 or $50 per RVU, and that's more in my bank account, and now I can get that fancy car or whatever, right? So I want to caution against conflating a very, very powerful test with what we do with that information, right? Because you can do bad stuff with data all the time, but the fact of the matter is that, as Anna has said, heart disease is the #1 killer in this country, and the rates are going up, and we do, forgive my language, a shitty job of catching people before their event. Dr. Summers has said, it depends on the research you look at, but anywhere between 15 and 30% of people, their first presentation for heart attack is sudden death. The first presentation of heart disease is sudden death, which means that by the time we learn that they're at risk, they're dead, right? And so we have to do something to stem this tide. We are losing the battle. For 100 years, heart disease has been the #1 killer, and we are not making a change, right? So I'm going to step onto my soapbox here for a second. And I apologize. You guys you're the question, so you're stuck with me now. We mandate colonoscopies at the age of, now it's like 45 for everybody, right? Colonoscopies are expensive. They require time off from work. They require sedation. There's a risk of death with colonoscopy. I don't know if anybody realizes that. It's like 1 in 10,000, 1 in 100,000 in that range. But there's a risk, right? Raise your hand if you know how many. So we do colonoscopies to prevent colon cancer, right? Ultimately, it's to prevent death from colon cancer. Raise your hand if you know how many people die each year from colon cancer. Now, I apologize if somebody here has a loved one that's been affected by colon cancer. I'm not trying to be insensitive, but it's 50,000. 50,000 people a year die from colon cancer. And we mandate an invasive, expensive test that requires sedation and makes you take time off of work. It makes you, reorder your life and everything to save 50,000 lives. Heart disease kills 1 million lives a year. And we don't mandate any screening test, right? So there's plenty of data that shows that in proper hands, calcium scores can be life-saving because they improve preventive treatments. And there's even been, there was a study, it was a retrospective analysis, but there was a study that actually looked at outcomes, hard outcomes, and there was a trend. It wasn't statistically significant, but there was certainly a trend towards improved outcomes from heart scans.
How do we get to that, right? How do we get to that?
Well, then you have to educate the physicians. You have to educate physicians to say that a score doesn't mean, I'm a preventive cardiologist, I order them all the time. I have nothing to gain by having them generate more procedures, because I don't do procedures. I don't do heart caths or surgeries or anything. I do them, and 80% of the patients I do them on never get anything more except nutrition counseling, exercise counseling, smoking cessation counseling, all that other stuff. So it's education of the physicians. There is a loose recommendation from the American Society of Nuclear Cardiology, which for a while was teamed up with the Society of Computed the SCCT, which is the CAT scan society. That if your percentile rank was greater than 75th percentile, then you should consider a stress test for that person, because that's a pretty high score. But that's independent then of the number, right? So as Anna was saying, a number of 20 in a 37-year-old means something very different, and a 57-year-old means something different in a 97-year-old. So instead of looking at the the absolute number, looking at the percentile rank, and saying that anybody above 75th percentile or 85th or whatever, maybe then they need, that's the gateway into more testing. But you know, that would be a very reasonable thing to do. Anybody less than 75% percentile, you know, should get counseling rather than a procedure. That'd be a reasonable approach.
Never reasonable when you're talking insurance company to physician. You know, it's a very, you have to get a consensus, right? So when we establish a general practice, there has to actually be a rule. And that's what's been the biggest struggle with this particular test. It's not the value of the results of the test and the fact that it does prove that there's an anomaly. It's what has been done.
For sure.
Primarily
but
in Wisconsin.
Right, but I would argue, just as, again, my goal is saving lives, I would argue that should not want us to do fewer of those tests because there's some bad actors doing the wrong things with the results. I think we should do more of them, catch people, and prevent the heart attacks that you end up paying for.
Yeah, well, that is a lag too, right? There was last
of our field. I think that there are a lot of times when we have predictions, family history is so underlooked. People don't know their family history sometimes, or they don't talk a lot about it, or they don't know specifically how severe it is. So the genetic testing is very much in evolution, but in the future could be very important. Then there's this like risk scoring of taking all these risk factors together, and there's very much not a standardized test, but there is a lot of interest in that, and big data, as we get better and better models able to process it, I think that we'll go towards that, and I think it's really helpful. The risk calculators we currently have to decide what people's risks are really miss a lot of people, and that's really unfortunate. Even with the calcium scores that we're talking about, just to make it clear, I was really frustrated years ago when they started offering those where you could just call and get it yourself. Because if someone gets a 0, a lot of times they're like, woohoo, free ticket. And it doesn't mean you can't that you shouldn't treat your risk factors. It means, yeah, you gotta treat your risk factors. Don't take your foot off the gas. It's just, hey, I'm not way behind. I don't have to be more aggressive on getting my numbers down. There are certain populations that calcium scores underestimate. Smokers, for some reason, have lower calcium scores than would be predicted. They're still very high risk. And when you put on the hat of women's health, women who smoke have a significantly higher risk from that smoking than men. So we really hit it hard when a woman comes in and is a smoker of like, this is probably, yeah, you're here for your cholesterol, but this is probably the biggest thing you could do for your health, is that we try to help you quit when you're ready. And so that's really important. Diabetics, huge segment of the population, also the calcium scores underestimate their risk. So there are times when that 0 isn't really a 0. You can still have soft plaque that isn't showing up. So you can't use only that. And that's why you really have to personalize it. And that's what I love about the training that Dr. Lieberman and I have had, is that really the comprehensive risk factors, it's beyond just cholesterol, it's all the risk factors for prevention that are so important. But we have to look beyond that. But there's not a great standardized one. There's a lot of excitement. Whenever there's something new, there's always like players that run in and say they're the best and it's gonna be awesome, and then they kind of fall by the wayside. But I think it's the future.